So thank you for joining me today. I'm going to call you Mo, but I'm going to allow you to introduce yourself. So you're my first guest, so thank you for joining me in this session. So tell me, introduce yourself to the world here.
Well, thank you, Dr. Hurley, for having me. It's an honor to be your first guest, to be honest. My name is Mohammad Doer. I'm a medical student in Lebanon. I'm a fourth-year medical student now. So I did a year of research at Brown with Dr. Alan Daniels and Dr. Basil Debo in the spine department. And my journey for research started like 5 years ago. It's when I wanted to do orthopedics. And as soon as I learned that I want to do orthopedics, I thought about doing it in the States because like they have the best programs, the innovation and everything. And if you want to really change orthopedics, if you want to do something big, it's where you have to go. And to go there, you have to do some research. And like it started as a means to an end, but then like it became something I'm really interested in. And fortunately, most of my mentors were spine surgeons, and some of them were shoulder surgeons as well. So like most of my research is in spine and shoulder surgery. And that's where I met Dr. Hurley at SRS, where I had a podium, and like we hit it off during a dinner. And he told me, send me your best paper. I did, and I kept sending him some papers after that. And it went great.
Yeah, that's good. So, Mo, tell me, what's the name of your medical school that you're attending there in Lebanon?
So yeah, it's St. Joseph University. It's one of the medical school, but it's the French system. Like it's one of the main medical schools, but it's in the French system. We have two others, like that's our American system.
That's great. That's great. So, and then you said you spent a year doing research with Dr. Daniels. Is that right, at Brown?
Yes, sir. I did a year there. Last year, I did a gap year between third and fourth, and now I'm like on the low between my time for exams and everything. I keep on doing research with them.
That's great. How, and just out of curiosity, I assume you probably were able to do quite a bit of research. Could you tell me a little bit about your research? What are you most excited about? How many publications? That sort of thing.
Yeah. So like when I first applied, I had like about 12 publications. But then like when I started there with the team, that was very productive. It was like amazing. I was able to get through 100 by the end of the year. It was like unheard of. Like, of course, it was hard work and everything, but like the team was very supportive, and we had all these ideas. And like, I used to come up with a lot of ideas, and it was like mainly about alignment, and it was like high quality studies with the ISSG and everything, and they are really changing spine surgery over there. They are doing a great job. Like, I'm honored to be part of their team.
That's great. That's great. And are you interested in orthopedics in general, or are you really just focused in on spine, or do you even know yet?
Like before I started this research here, spine surgery wasn't something I wanted to do, like, to be honest, because like back in Lebanon, and mainly a lot of spine surgeons, like it's a very slow surgery. Like it takes 2 to 3 hours, 4 hours sometimes, depending on the surgeon. But then like I was exposed. And it's very complex. Like, if you don't have the right mentor, you'll get lost in it. You're not going to understand anything. And it's very hard. But fortunately, I have had good mentors in spine. And, like, I was able to shadow Dr. Daniels. He's very fast and he's very good. And, like, this year of spine research changed my mind. And it's, like, something I really consider now as a top choice. But, yeah, I'm still interested in orthopedics in general. But, like, maybe 60 or 70% spine is what I want to do.
That's great. That's great. Well, obviously, I wish you the best of luck in your endeavors, and obviously, I'm rooting for you to get accepted into a into a residency program in the United States. Obviously.
Yeah, thank you. Well, I'm applying next year, so fingers crossed.
I was gonna say you're gonna be applying next year, right?
Yeah, upcoming cycle. Time to start preparing.
That's great. So I would assume you're going to apply, kind of cast a big net.
Yeah, but now with we only have 30 signals, I don't think it's useful to apply more than 30 programs because they're not going to look at you if you don't signal them.
Got it. Gotcha.
So it's going to be 30
Well,
programs.
Okay. So does that mean will you be traveling to the United States quite a bit then to interview, or do you think most of them will be done kind of in this fashion online too?
Well, no, I'm going to be in the United States next year. I'm going to be taking a position as a shoulder and elbow research fellow. He's another mentor that I met. He's in the United States at Rothman in Philly. And I'm going to keep on trying working spine in my spare time when I have the time and applying. So, yeah, it's going to be exciting. And I'm planning to like look at the interplay between the shoulder and the C-spine. It's something I really want to study.
Yeah, there's a lot of crossover there in terms of pathology and like presentation of symptoms and whatnot. Yeah, so that's pretty cool. I like that. Well, hey, so let's talk about your paper.
Yeah, well, this is one of the best papers I've wrote yet. Like Dr. Sibali, he's one of them. You met him at SRS. He's one of the mentors here in Lebanon at Hotel Dieu.
Okay.
Like he said, hey, why don't we look at ALIF versus TILIF at L5S1? And I said, no, we shouldn't because like it's already been done. Like there's not enough studies. He said, no, it's not been done. He said, the studies that have been done looked at ALIF versus TILIF at like various levels of the spine, and we both know like at L5S1 it's not the same at L2, L1, or L3, L4, because like the biomechanics of L5S1 and improving alignment there may have a greater impact on the whole spine. And I talked with Dr. Daniels about this. He says that's a great paper, and he's very interested in the subject. A lot of his publication is about promoting ALIF. And so, yeah, it took a bit of time. I had some help, and we were able to publish it in Spine.
Yeah, that's great. So what's the official title? Can you tell us what the official title of your paper is?
So it's transforaminal versus anterior lumbar interbody fusion at L5S1 for degenerative spine disease and meta-analysis.
Yeah, so it's a meta-analysis. So,
yep.
I mean, I know what a meta-analysis is. You know what it is, but for people that are watching, what's a meta-analysis?
Of course, so meta-analysis could be it could be level 1 evidence or it could be a level 3. It's all depending on the studies you include in this meta-analysis. So, unfortunately, in orthopedics, we don't have that many level 1 studies, randomized controlled trials. Like, there's not that many of that. So, for this study, we had to use only retrospective studies. That's what is available in the literature. And we compiled the evidence across all these studies to get like one synthetic statement to see, like, is this really true? Or like, are what the study's saying, is it really true or is it's not true? Like, is it significant or not? So that's what we did. And we compared TILIF versus ALIF, a huge debate in spine literature. And, well, I'm not going to spoil the answer now, but we got a clear winner.
Yeah, that's true. You did. And so, I mean, like, I feel like I kind of know why this is an important question. I'm just kind of curious from the perspective of a medical student. Tell me why you think this is such an important question.
Well, I think it is an important question, first of all, because like Amr Sibali, he's my mentor here, as I said, in Lebanon. In Lebanon, we don't do that many ALIFs. It's costly. OR times increase, and we'd have to flip the patient. Like, not a lot of insurance are gonna cover that because they're gonna see, look, TILIF is as good as ALIF, so we don't do that. And if you tell the patient that, hey, we can't do, we're gonna have to do an ALIF here, he's gonna go to another surgeon who's gonna tell him we can do an TILIF and it's gonna cost you less. So it's not very feasible to do it here in the ALIF. That's why my mentor here always says like a TILIF is very good. But when I went to the States, ALIF is king, you know? So I kind of had this question like in my mind, like, is really TILIF good or is ALIF better? So that's where I had this huge debate. Yeah,
so, I mean, in my mind, I mean, you have a very unique perspective, right? Because you have the perspective of somebody who's not necessarily practicing here. So, you know, we in my own personal practice, we use ALIF quite a bit. But I also use the TIFF approach, the transforaminal lumbar interbody fusion approach, quite a bit as well. And I have an interesting story. So years ago, I was sitting down to dinner. I had the opportunity to sit down and talk to Juan Aribe. Are you familiar with Dr. Aribe?
No. Oh yeah. Juan,
So Dr. Aribe,
Dr.
he's
Juan,
he's
a part of the ISSG.
neurosurgeon.
Yeah.
Yes, exactly. So I had the opportunity to sit down with him, and I asked him a question at the end of dinner. I said, if there was one thing that you could say to, Juan Aribe, 20 years ago when you first started your practice, what would you tell him? And he said, do more anterior lumbar interbody fusions at L5S1. So it kind of had an impact on me at the time, because I was I was very early on in my career. I think I was like either a first year or second year resident. So it had an impact on me. I thought, that's an interesting perspective. Because at the time when I was doing my training, we were only doing primarily if it was an index procedure. In other words, the patient had never had spine surgery before and they needed a fusion done. We were doing a lot of transforaminal lumbar interbody fusions at L5S1, right? And essentially the patients that got ALIFs or anterior lumbar interbody fusions, they were the patients that were going back for some revision, essentially, right? So either they didn't fuse, or there was some other issue that we were trying to address. And so kind of to hear him say that at that juncture in my career, I thought, interesting, okay. And there's complications that can happen with any surgery that we do. So let's kind of talk about that, because you started looking at the differences in complications in your paper. So maybe give us the highlights of what you discovered.
Yeah, so we showed that ALIF had a low rate of complications and a low rate of subsequent reoperations. But what I failed to show is we didn't have enough numbers to see, was it adjacent segment disease, was it pseudoarthrosis? We didn't have the exact numbers to see what was the profile of complications in each surgery. But from the literature, we can see that the problems in ALIF are mainly visceral and approach-related complications. These drive the higher numbers of complication in ALIF, whereas in TIFF it's mainly adjacent segment disease. I don't know if that's what you see in your practice. What are your insights about it?
Yeah, so I would say in my own practice, the complications that I see are, first of all, it depends on the approach, right? So we do kind of a couple different approaches. So some of my patients will get just a transverse incision, like a low transverse incision, and my vascular approach surgeon who helps me, he's phenomenal. His name is Wayne Causey. He's a vascular surgeon at Brooke Army Medical Center, and what he'll do is he'll do a low transverse incision, and we'll actually do a right-sided retroperitoneal approach if we're going down to L5S1 for the most part, simply because Wayne has gotten really facile in his career. He's had really good outcomes, and what he's realized is that if we're doing a case at L5S1, there's a potential that they may need an additional retroperitoneal approach at some point in the future, right? So what he's trying to do now is do primarily right-sided retroperitoneal approaches when we're going to L5S1, and that allows us to go back in on the left side if we ever have to do a retroperitoneal approach from the other side at 3, 4, 4, 5, whatever the case may be at some point down the road if we had to do that. So we've been doing that a lot, but sometimes when you do a low transverse approach, you have to create larger soft tissue planes, right? And so one of the complications that we've seen is that you can get hematoma forms more readily in that space because of the soft tissue planes that we're making, or you can get a seroma. It doesn't necessarily have to be a hematoma, but just a soft tissue fluid collection can form. We've also seen that there's complications that can happen from a vascular standpoint, right? That's for the most part probably dependent on your approach surgeon's experience, probably more so than anything else. Wayne has a very low complication rate when it comes to vascular injuries, and we do a lot in terms of preoperative planning, right? We look at the vessels kind of extensively preoperatively. We talk about things. We make sure it's going to be safe. We kind of look for that median sacral vein as we go in, and look to make sure that we're going to have some, the right stuff to clip it or to tie it if we need to. And then for men, obviously, there's the risk for retrograde ejaculation. So actually, in our practice, one thing that we've been trying to do is we tried not to use any, even any bipolar or any electric cautery. We try and actually just bluntly dissect to try and help prevent any sort of complication from that perspective. So
is it working?
I would still say that, there's probably a rate of, somewhere between 2 and 6% in our population, but I don't think that it's quite as maybe high as what some papers have suggested.
Yeah. Have you ever tried doing an ALIF without access surgeon? Because we don't have access to vascular surgeons here that's gonna do our approach for ALIF.
So I personally have not done my own ALIF approaches, and the reason I haven't has been mostly just because, I've always been a little cautious about the idea of doing my own approach and then having a complication and having to call somebody in. I mean, in my perspective, I try and put myself in the other surgeon's shoes, right? So I don't want to do something and then, Wayne is so readily available to help me anyway. I don't want to do something where I'm like, well, I had this complication, and he might be like, well, why didn't you just call me in the first place? Like, I'm around, I'm willing to help you. So, from that perspective, I just haven't done my own ALIF approaches. It's not to say that you can't. In fact, there are, spine surgeons that do. I just have kind of made the decision to do it in conjunction with somebody who's got more experience than me, somebody who can probably do it safer than me. And so that's kind of like where my head's at in terms of my decision-making process.
Yeah, it was actually one of the reviewers' comment. Like, you can see in the discussion, I write a statement is sometimes spine surgeons can't do the approach without an access surgeon. It's completely safe. It's because one of the reviewers told me, like, you can't just say that we need access surgeons for every ALIF.
Yeah, I mean, here, at least in my own practice, the vascular approach surgeons have just been more than happy to come and help. So from my perspective, I'm going to utilize, their expertise. It's just very easy. I mean, sure, there's some scheduling, issues that you run into from time to time, but for the most part, I mean, they're very accommodating and more than willing to help out. And I think it's probably in the patient's best interest anyway. So that's kind of why we try and do it that way.
Yep.
So as it relates to complications, so you saw some differences in complication rates, I think, with TLIF versus ALIF. I remember reading about them. I remember, thinking about how that was interesting. But maybe expand a little bit on what you saw.
So, in regards to complications.
Yeah, I think you saw, for instance, in the TLIF cohort, I think maybe you saw a little bit more blood loss in the open TLIF cohort, if I'm not mistaken. Maybe a little bit increased length of stay or something. Yeah.
So we did look at OR time and blood loss and length of stay. So the thing is, in studies, some of the studies included MIS TLIF or open TLIF.
Right.
And so when looking at EBL, we were only able to find a significance between open TLIF and ALIF. And comparing open TLIF to ALIF, we had a higher blood loss in open TLIF. And it's understandable because in TLIF, you go through the muscles, through the tissues. And this could be one of the reasons, which is why we have higher complications in TLIF, because a lot of studies have published if you have more blood loss, well, you have higher rate of complications in the short term, during the hospital stay. Mainly there are medical complications. But yeah.
And then you did see a difference too in a segmental lordosis too, I think, right?
Yes. So I did look at the improvement in segmental and lumbar lordosis, and we saw that with ALIF there's a greater restoration of both segmental and lumbar lordosis. And this could be one of the reasons, which is why we have a lower rate of complications in ALIF, because similarly, many studies have showed that restoring alignment in short lumbar fusions has shown to decrease the rate of adjacent segment disease and reoperations. A recent study published by the Brown team in the Spine Journal showed that if you don't maintain L4S1 between 35 and 45 degrees, you have a higher rate of adjacent segment degeneration and reoperations. But I was not able to show a difference in adjacent segment disease specifically between the two groups. It was mainly due to the low numbers, probably. I'm going to keep my eye out on some new studies. Maybe I can compile them and do a new meta-analysis about this.
Well, I think also part of the, one of the confounding factors here too is that I think the time frame of follow-up was probably a little short too in terms of
yes, it was 1.8 years, I think, but it was similar for both, which is good.
Yeah,
there was no bias about that.
In terms of trying to gauge adjacent segment disease, I mean it's a time dependent. Usually it's a time dependent thing, right? So, but I would say from my own personal experience, being in my 7th year practice, I mean the patients that you do a good job of restoring lumbar lordosis, especially at the very bottom of their spine at L5S1. I do think that it is having an impact. I mean, it's hard to say because I don't have the exact numbers to prove it, but it does seem like there's an improvement, at least in the long term. And maybe I'm speculating to some extent, but it does seem to me like the patients who are getting ALIF, who are having 15, 20, 25 degree cages placed at those levels. Good restoration of the posterior disc height, 8 millimeters or so is kind of my target. I don't know what Dr. Daniels does. I don't, the people that you follow too may have their own specific targets. But I try and run everybody through SurgiMap. Are you familiar with SurgiMap?
Yep.
Yeah. I try and run the patients, their full standing films through SurgiMap. Even if I'm doing a single level procedure, right? I still run it through SurgiMap. I still make sure I've got my parameters kind of dialed in, and then I try and use that to try and help guide how I'm gonna treat somebody. So, I mean, I'm hopeful that I'm having a positive impact, and I hope I'm not creating an adjacent segment disease problem down the road at some point. But yeah, that's my goal.
Well, speaking about restoring and planning short fusions on SurgiMap, the team published I think it was last year. They published a paper in JBJS. It was a current concepts review about restoring alignment in degen fusion. It's open access. It's published open access on JBJS. Check it out. It's a really nice paper. I wasn't part of this, but I read it and it's amazing. I think it's the cornerstone for what they use.
Yeah, will you send that to me? I would like to review that. Yeah.
Yeah, I'll send it.
I'll even flash it up on the screen here after you send it to me, so that we can have our viewers be familiar with it too.
Yeah, I'll send it in a minute. Do you want me to send it now or?
No. You can do it when we get
done.
Right. So.
Yeah, perfect.
And then, so one question I always like to ask my residents anyway, when we talk about a paper, how does this paper change your practice?
Sorry, it's cutting. I couldn't hear the question.
Oh no, it's okay. I said, how would your paper influence or change your practice?
Well, if I end up doing spine, hopefully, I think I'm gonna be doing when I'm gonna have the chance to do either an ALIF or a TIFF. If I have the indications to do either or, I'm gonna go with an ALIF. But we're gonna see what the data is gonna show in 5 to 6 years from now. But yeah.
Yeah.
Do you think that's a good decision?
I think that the best decision is to try and recreate the appropriate lordosis and achieve a solid fusion. Do something that's going to be durable long term for the patient, right? Whether or not it means a TLIF, whether or not it means an ALIF, you just need to do a good. You need to be planning ahead and hopefully not creating a problem for them, right? You don't want to fuse somebody flat. We know that's a problem. There's more than 750 published papers out there talking about the downsides of doing that. So I think you can do a good, TLIF. You can't. I mean, Ernie Braxton. Do you know who that is? He's a neurosurgeon in Vail, Colorado.
No.
Okay, well he's got a lot. I mean, he trained me. He's got a lot of followers online. He posts a lot of pictures of the transfemoral lumbar interbody fusions that he does. He does completely wide awake surgery, so it'd be really challenging for him to do an ALIF, I would think, because for the most part they need to be relaxed. In order to be relaxed, you got to be intubated. So his patients are wide awake. None of them ever go to sleep, and he he primarily does a lot of TLIFs. So, but he achieves really, really good lordosis, and he does it through a very, very interesting technique. He uses this nice expandable interbody. And I even kind of talked to you about this after we kind of looked at this paper together. Part of me thinks, a really cool, paper, prospective paper would be to take a cohort of patients, put them in the ALIF, cohort, and they get a purely indirect decompression, right? So maybe you separate patients out and they get an ALIF in this cohort with percutaneous screw fixation to hold things in place. And then in the other cohort, you do a purely, TLIF approach. But this is where you specify how the TLIF is done, right? So in this TLIF cohort, you do bilateral facetectomies. You really do everything you can to provide the best direct decompression possible, because that's the main benefit, I think, in my opinion, of doing a TLIF, right? You get a nice direct decompression of the nerve roots. But then in the disc space, use like a nice interbody device that allows you to really recreate the lordosis that they need, that you would be able to do. Even Kern Singh has shown some pictures of this. Basically, do an ALIF from a TLIF approach, right? I mean, that would be amazing if you could do that. And so there are some devices out there now that kind of like allow you to do that. And compare those two, right? So purely indirect decompression cohort to nice direct decompressive cohort, and then follow those patients out long term to see if there really is a huge difference. That would be where I would want to go in the pursuit of really trying to answer this question.
Well, that is interesting, but I know you weren't very happy with the study we're about to publish. It got minor revision from the Spine Journal, where we compared static and expandable TLIF. We showed no difference in restoring lordosis. But I mean, not all of them did bilateral facetectomies. There was a lot of limitations in the study, because it depends on the mechanism of expansion of the cage and on the size and everything. But a good study
and to your,
would be the one you proposed.
To your point, not all implants are the same, right? So maybe the key there is learning, which implants allow you to get the best lordotic correction with the least amount of subsidence, right? So maybe that could be elucidated in some of the future studies. I don't know, and which ones have the best fusion rates? Hard to know, but also hopefully something that we can get to the bottom of, through more research, through people who are willing to do fellowships and teach us the way.
Couldn't hear you. Sorry. Keeps on cutting.
That's okay. No, that's okay. I was just saying that people like you who do fellowships and do all this research are teaching us the way, and we appreciate that.
Oh, thank you. Thank you. No, we're just learning now. We're learning from you guys.
Yeah. Well, I know we've had a few little technical difficulties here. This has been a little eye-opening for me in terms of seeing what we can accomplish online. But hopefully the quality of this is good, and hopefully well, first of all,
hopefully it will end up being a good
hopefully people will have learned something by our discussion today. But I think that for me personally, it was really cool to have you on and talk about the paper, and I'm really proud of you for your publication, and I wish you a lot of success in your endeavors, and I hope you get in next year.
Thank you. Fingers crossed, and thank you. It was really an honor to be your first guest in here. So
yeah. Well, send us that paper that surgery paper you talked about. Yeah. And we look forward to reading that too.
All right, I'll do that right now. Thank you.
Okay. Hey, have a great day.
You too. Thank you for having me.